So now I'd like to welcome back Dr. Gerald Falchuk and Dr. Andrew McKenzie for our panel discussion. Additionally, to round out our panel, we invited Dr. Richard Geer and Dr. Andrew Kennedy to join us. So we've got all perspectives on treatments. We have Dr. Richard Geer serves as the physician in chief for surgical oncology at Sarah Cannon Research Institute while treating patients here in Nashville. And Dr. Andrew Kennedy serves as the physician in chief of radiation oncology and the director of radiation oncology research at Sarah Cannon Research Institute, also treating patients in Nashville. So thank you everyone for joining us this evening. So our first question, I'll start with Dr. Falchuk. So Dr. Falchuk, you kind of touched on this, with the BRAF. So how exciting was it to see the BRAF experience? So, you have these medications and trials, and, just like you showed that picture of such a dramatic response, I'm sure that had to be a pretty exciting day.
Yeah. This was maybe the most exciting time of my career, or at least it certainly was at that time. For perspective, at that time, for patients with metastatic melanoma, there hadn't been a new drug approved for melanoma for more than 20 years, maybe 30 years. And those of us that were seeing patients with melanoma, this was really an injection of hope that we hadn't seen in a long time. And it really opened up the whole world to what possibilities may be out there. Treatment for melanoma has changed dramatically over the last 10 years. And because patients are interested in clinical trials, doctors are pursuing new treatments for melanoma. It's all of us working together.
Great. And so, Dr. McKenzie, a patient had asked, are there trials, are we seeing opportunities come through for patients that are BRAF wild type, but with an NRAS mutation? And so you actually touched on this in a little bit in your presentation, that we are seeing some options coming through.
Yeah, it's a really great question, because as you saw from my prevalence slide, NRAS mutated cancers are not all that rare. There's actually quite a few patients who might have those NRAS mutations. And the tricky part with RAS, NRAS, KRAS, HRAS, they're all part of the same family, is that they're very smooth molecules, hard to develop drugs that will get in there and bind to these molecules. And so what we've had to do is be creative about targeting things maybe just around or just outside of NRAS or beside HRAS and KRAS and NRAS. And so there are a plethora of studies that are looking for these sort of adapter proteins that are surrounding NRAS, to try to exploit those molecules and inhibit how NRAS functions downstream. And so, yeah, I think that's a really awesome area of investigation. I know that you and Dr. Falchuk both have studies that are trying to find out if those types of approaches are going to work. So it's an exciting place to be in right now. And I would encourage that person to reach out and look for a study that's targeting those NRAS mutant tumors.
I'd like to add a comment to that. Some of these studies are already showing responses in patients with NRAS mutated melanoma. These are recent results presented at our big conference this year. So any patient with an NRAS mutation who's interested in clinical trials should have that discussion with their physician and seek out those trial options.
Yeah, great point, Dr. Falchuk. So we'll switch gears to Dr. Geer. So one of the patients had commented that they had a history of stage 3C melanoma back in 2009. So 12 years ago, they received immunotherapy 4 times in the hospital and surgery. And so they had wondered kind of what type of therapy that was. I'm assuming it was interferon. And they said, what happened to that type of therapy? And, they said they're so thankful to be alive today. So just appreciate your perspective on how treatment for when a patient comes to you, how different your perspective is on treatment back then when all we had was interferon and today.
Yeah, well, you have a good point. I mean, unfortunately, I've been through the time where, and Gerald said we had the first treatment was 30 years ago. We may have had treatment, but it certainly didn't work very well in terms of what we had for our patients. And we didn't have anything really in the adjuvant setting. So if you had resection of a melanoma and you had lymph nodes taken, the question was always, what was the next thing to do? And it's like this patient had interferon, and interferon was a drug that we gave for a long time, but it was a really tough drug. Oftentimes these patients were in the hospital in the ICU getting through their therapy, and it was nothing like what we have now. I think Skip Burris always gives me the analogy of what we're trying to do now is if we have a light switch, interferon actually was, it's like sometimes chemotherapy where we're taking a double barrel shotgun to turn the light switch off. And now we can go over the light switch and just take our finger with this BRAF and all these other things in our immunotherapy, just be able to turn off and try to decrease our collateral damage. But the amazing thing to me is how far we've come in melanoma just in the last 10 years. It has been incredible to see. You and I had a patient together, head and neck melanoma, nodal disease, came back, I think 4 months later with more nodal disease in the neck. I did a radical neck dissection. By the time I finished it, there was still more nodal disease. Actually had the vaccine that Bobby had, but had disease measurable in basically NED at this point in time, 2 years later. So incredible how things have happened.
Yeah, great. It's so exciting to be able to talk about all these new options. And my hope is that we continue to make the same strides, as much progress as we have. So Dr. Falchuk and Dr. McKenzie, you might end up joining in on this one. Someone had written in, what if there's no mutations? What does this mean for treatment options and outcomes?
Yeah, hope is not lost. I'd say hope is not lost if that's what this person is wondering. Immunotherapies are not based around a single mutation or even a couple of mutations. I think immunotherapies really change the landscape for those patients who don't have a BRAF mutation or an NRAS mutation or a KIT mutation. And on top of that, new things are being found all the time. Genes that we thought were irrelevant are now critical. So I think there's still a lot for us to learn and discover and make treatment better.
Yeah, and Dr. Falchuk, I'll add to that whenever I hear that there were no mutations found in a cancer, I'm always skeptical of what tests were run and how complete the coverage were for those tests. And so just a word of caution and encouragement to ask those questions to your doctor. How many genes were on the panel that we tested, and was it a 3-gene test, or did we cover 300 like the panels that you use, Dr. Falchuk? Because sometimes they might not be negative for no mutations, but they just didn't test all of the different genes that we see these mutations in. So that's another caveat that you might want to, again, talk to your doctor about, and I encourage patients to do that.
That's a great point. So Dr. Kennedy, so we've had advances in systemic therapies, but from a radiation standpoint, when do you think, for stage 3 melanoma, is there a time that patients should be considering radiation? And then would love to get your thoughts on when some scenarios that palliative radiation could be helpful.
Sure. And I've really enjoyed all the presentations of the all-star lineup, really exciting systemic things presenting. Radiation does have some terrific newer technology for directing radiation in places where we think melanoma cells might be hiding and doing it in a very safe way. But to your first point on when adding it in locally advanced, there are some indications, particularly lymph node positive patients or residual disease after a resection. There are a few times when we get involved early on in even earlier stage patients, but because of all the presentations that everyone has just heard, we sometimes just don't want to get in the way of that unless there's a compelling reason to delay things and give radiation over 5 weeks. So I think that of the most exciting things that radiation perhaps can provide nowadays is the use of what we call stereotactic radiation. And it is not brand new, but it has evolved over the past 25 years to a point where we treat diseases in many parts of the body, not just the brain, with this special approach. And listeners may have heard the term oligometastatic disease, meaning it's in more than one place outside of the skin or a lymph node. And there is progress not only in technically delivering the radiation dose very carefully, but in learning that we don't need to do maybe as much or as many treatments as we've done in the past. We can get the same result safely with 1 to 3 or 5 treatments where we used to give 20 or 30. So the technologies on the one hand, and then just evolving and learning that there are perhaps less invasive or less difficult ways for patients to get the benefit of targeted radiotherapy.
And I know one question that a lot of patients ask is about proton therapy. So I don't know if you have just an easy way for patients to think through, is that anything that you recommend for melanoma patients, or is there even data in melanoma?
Well, protons, as the number of proton centers has grown in the United States and worldwide, it's a very common question. I field that question from new patients every week. We are fortunate here in Nashville to have access to a proton accelerator. I also treat a variety of tumors for which there is some evidence that perhaps proton approach could be better in some respects. But what I try to emphasize to patients is the selection of protons versus regular radiation is somewhat of a secondary decision. The decision, first of all, is a multidisciplinary team feel that radiation is really what's needed next. And then what's the best tool to do that? Sometimes it's stereotactic. Sometimes it may be protons. The proton beam itself doesn't kill melanoma cells any better than regular radiation kills them on the actual physical breaking the DNA. Where there could be advantages to a proton approach is in limiting the radiation from passing through the tumor and going into other normal tissues. And so if you think of radiation, traditional radiation is somewhat like a bullet. It's going to go through and into the concrete that's 6 feet thick, whereas protons can stop literally anywhere you want them to in the body. So depending on the part of the body that you're wanting to target, the tools that might be best might be protons. There are other technologies that are not as elegant, let's say, as protons. And this is an old school way, but brachytherapy, where you physically put radiation next to or inside of a tumor. And there's an intense amount of radiation there, but it doesn't go outside the tumor. And there are times when that tool is the best tool. So I would say if there's a proton facility in your town, that's wonderful. You have access then to all the toys we have in the toy box, but certainly get the advice of your team to see if radiation is the next best step. And also in your particular case, might the use of protons be no different than regular photons? And the reason I say that is that often insurance carriers either don't cover protons or they have very high copays. And so it's the keeping patients whole and keeping their toxicity down includes financial toxicity. So we want to employ the really exotic tools when they're really the best tool, but not when they're perhaps not giving benefit.
Mm-hmm. Great. Yeah, great point. I mean, I think it's great to have new technology, but then to have to think through, is it the best use? Is it the best tool? And then all those other considerations. So we've gotten a couple questions about immunotherapies and patients that have pre-existing conditions, whether that's rheumatoid arthritis or lupus. So one question, Dr. Falchuk, so will immunotherapy be available for those with concurrent autoimmune disease? And so I think there's probably two parts to that question. One would be standard of care, and then the other for clinical trials.
I think that's the right way to conceptualize it. I'll talk about the clinical trial aspect first. So we do know that patients who have autoimmune diseases are at higher risk for side effects when they get an immunotherapy drug or most immunotherapy drugs. That's been pretty well established, and this was suspected early on based on the mechanism. The FDA oversees the regulation of all clinical trials, and part of the job of the FDA is to make sure that clinical trials are safe. Patients who are at higher risk for having side effects maybe shouldn't be on a clinical trial. And so from all the FDA guidance I've seen, patients who have autoimmune disease, or at least autoimmune disease requiring treatment, are typically excluded from those clinical trials. There are exceptions, because there's some autoimmune diseases that aren't very active or require minimal treatment, don't require steroids. Some trials, many trials, permit those patients, but each one's a little bit different. So I think from a clinical trial standpoint, it's really on a trial by trial basis what the rules are going to be, but it's all going to be based on FDA guidance. From the standard of care standpoint, the risk for a patient who has autoimmune disease to get that treatment, I think it's not an absolute contraindication. Dr. McKee may have additional thoughts on that, but it's certainly a different risk benefit calculation. I know of at least one study that's been presented, published, showing how patients do when they have autoimmune disease and they get immunotherapy. They certainly do respond, but they also certainly have more toxicity. And then it's a discussion to have with your treating physician whether it's worth that additional risk.
Great. Yeah, I agree. I think immune therapy, we've obviously seen some fantastic results, and it's a matter of for trial, looking at the criteria, and for standard of care, trying to determine, very different for patients that have Crohn's on multiple medications to try to keep it well controlled versus a patient that's had, pretty well controlled psoriasis, and has been disease-free for an extended period of time, and potentially considering it for that patient, in a standard of care setting. So it's a great question. We've had a couple of questions about triplet therapy, and I'll say, this is definitely one of the more recent FDA approvals for melanoma therapy. And so that's giving anti-PD-1 with the targeted therapy, and which patients we use that for. I'll say in general, I don't think there's been a significant uptake of that triplet regimen, because it can come with more side effects. So you have the immune therapy and targeted therapy. And so I think it's worth discussing with your physician. I think we tend to use it for patients that have more aggressive disease when they're first presenting. Obviously, you have to have a BRAF mutation, and treating pretty aggressively up front. Another question was, is BRAF MEK treatment effect durable? And I think actually I'd like both Dr. Falchuk and Dr. Geer to answer that. One is it durable? And then I think it leads us to think, when does it make sense to go in and do surgery, maybe radiation, if a patient's been on treatment for a while and we see changes on imaging? What things would you look for, and is that a time when would surgery be helpful in that situation?
I guess I'll start, let Gerald talk about the other, but we certainly have patients that we have oligometastatic disease, which is just a few tumors. And sometimes we do go ahead, and if they're resectable, something we can take it out, it kind of takes out this big clump of immune cells that sometimes are cells that overwhelm the body and make things less effective. You and I have a patient currently. This can have 12 years out from a melanoma of the leg, and has basically a single node in her groin. and nothing anywhere else. And so I think we're going to start by getting that out, and then probably think you're going to plan to treat her beyond that. So years ago, the only thing we kind of had was surgery sometimes, and sometimes we would be able to go in and take out these tumors. I've taken everything out from pancreas resections to sometimes liver to other things, and we can get a response from these patients for a long time before we really were in the immunotherapy component of what we did. So I think that the bottom line about melanoma, it is extremely a tumor that's very sensitive to the immune system, more than almost anything else we see in terms of how we do it. And I think that's why our treatments have been so effective. And sometimes why years ago we would do patients with metastatic disease and they would have a long-term durable, no evidence of disease for a long time. And then they would get into something where, sometimes women that got pregnant or something happened with their general wellness, their immune system wasn't as good, and they would develop recurrent disease. So kind of my thought about that.
I'll make a comment too regarding the durability of response with BRAF and MEK inhibitors. And one, I guess I'll say each person might have a different idea of what durable means, how long would count as durable. With the BRAF inhibitor by itself, the average length of response is in the range of 8 months. With the combination, more like 10 to 12 months. It's in that range. And the truth is that's only an average. An average means that half will do better and half will do worse. I have certainly seen patients with very long, very durable responses, more than a year, more than 2 years, 3 years, really long lasting responses. It's really a bell curve of how much benefit we may see. And some patients on that end of the bell curve can have a very, very long benefit.
Great. I think, just starting to see more and more of that long-term data on both targeted therapy and immune therapy has been exciting to see. So for the next question, Dr. Kennedy, we had some questions coming through about asking with the combination of immune therapy and radiation. So thoughts on that combination?
Sure. The majority of the times we're asked to intervene with radiation and someone is on immune therapy is when there are brain metastases or spread somewhere in the body that needs radiation fairly soon. And as many people know, a lot of these immune therapies do retain their effect in the body for some time, not just hours or days, but sometimes months. And fortunately, all of the literature to date, including some research we've done at SCRI, has shown that there isn't an increase in radiation toxicity when the most common immunotherapy drugs are used. So we typically don't stop them if they're being effective when we're going to do stereotactic. It's been less well tested if you're doing larger field radiation, but that's fairly unusual. So at least here in Nashville, Sarah Cannon, we continue with their ongoing immunotherapy and then selectively target the lesions in the brain or near the spinal cord or something and treat right through it.
Great. And Dr. McKenzie, so one of our questions for melanoma that's progressed on immune therapy, what data is helpful to guide treatment options? What category of options could this point to? And I'd say this is, the primary scenario, right, that you'll see these reports. And so appreciate your thoughts on this.
Yeah, thanks. And I would say that's a really, there's a lot of options that exist in that space. And that's where I think doing the types of testing that we talked about with next generation sequencing can be really helpful. So the classic things that you look for in melanoma, like BRAF, NRAS, and others, are probably done up front at the time of diagnosis. And then you go through things like immunotherapy and others, and then you're kind of stuck with, well, what's next? And that's where these types of tests are really helpful. I'll highlight one particular study, and Dr. McCain, you can probably comment on it, that is looking for patients who have mutations in this protein called GNAQ or GNA11. And it inhibits one of the most prolific kinases that exists inside of the cells, PKC. Patients who have this particular mutation are candidates for this study, and we've seen some really incredible responses. That's not a gene that's tested as a part of what we call standard kind of workups for melanoma, but is tested on these broad-based next-generation sequencing panels that, as Dr. Falchuk alluded to, test things like 300 different genes. It's one of the genes on those panels. And it's only through getting access to those types of tests that you'll find mutations that could make you a potential candidate for a study like that. That's one of potentially hundreds of different options that a patient might have in a post-immunotherapy world. And so, Dr. McCain, I'd love to hear your thoughts on that type of mechanism of action and others that you see in the clinic that are all really hopeful for a response that you only get if you're doing the NGS types of testing.
Mm-hmm. Yeah, I mean, I think if there's one takeaway for our participants is that, definitely make sure and talk to your doctor about your options, but also making sure that you've had that comprehensive profiling completed on your tumor. I think other ways that for clinical trials that we look at eligibility is doing pre-screens as well. And so even though we have genomic testing that's looking at likely doing DNA, sometimes RNA sequencing, there's certain studies that will look for proteins specifically for certain patients to see if that treatment would be a good option. And so there's a lot of really personalized ways of trying to find the best treatment for a patient. But agree with making sure you've had the comprehensive testing done and that it's been more recent. Like you said, a lot of times it's done up front, and that's how we find these treatment options like the GNAQ11, specific targeted treatments. Well, great. Well, thank you all so much for joining the panel tonight. We really appreciated your thoughts, your input. We've got even more questions that I know we'd all love to get to, but really appreciated everyone participating. So thank you all.